of the things that like y'all will see if you're doing the family practice and stuff, because individuals will be coming into y'all saying, I have this, what is this? Am I gonna die? Okay, so it's stuff like that. But also if you're examining of their chest or of their back, legs, feet, anywhere, you would see something and be like, how long has that been there? What is that? You know, this back and forth. So everything in here, which is a lot of them, are all of the benign things. One of the most important parts for y'all to know is what it could look like. Okay, what would have you concerned about it? What am I going to test? Labs, rads, all of the stuff like that. So this is what we could know what it looks like and what it is. These things, it can be all over. It can be of a single one. It could be like entire back and legs and everything. So this just breaks them down. How important is just to know this slide? Okay, so we'll get into all of those ones. Seborrheic keratosis, most common benign cutaneous neoplasm. Okay, so it's one of those that is the most common. What is it? It's immature sites. Okay, so it's those things that are there. Like everything that is in here with the dermatology, it can be just because of our sun exposure. It is going to say this over and over and over, how it's more of the pale, the light skins that are exposed to those things, and it picks it up. It can, it starts off as of a macule, but it can also then progress in a papular or the other one, verrucous. So how is it? Middle age, right? So it's those of the individuals who are exposing themselves to the sun, as I said, of the sun. Damage is why it's more of the lighter skin. It can also be of the family stuff, right? Because we always ask them, what's the family history, right? So it's there. Discrete, raised, rough, or hyper keratotic papules to plaques, stuck on, greasy appearance. It's often stuck on, greasy appearance. We can have this on the face, the back, the chest, the groin, everywhere that we have some of the hair growing. Is it malignant? No. Okay, this is what we're going to say on every single one of these derms. It will also say on every single slide, when in doubt, test it, biopsy it, chop it off, scrape it. Pick that stuff with every one of these, especially this one that's stuck on greasy. Here are some of the pictures there. Again, we will have the characteristics of what we think that it is to act like this. Hand lens, those are those beautiful things that Mr. Booth was passing around to y'all, things so that you can just focus in and it makes it. Again, when in doubt, biopsy it. These things are all of benign ones that we don't have to do any of the treatments on these things. However, we will have some patients to come in just because they don't like how it looks, what the people think, what does that patient think That's going to be all of the question. So we don't have to treat it, but unless we want to make our patient happy. So what we do? Well, if they want it, we could do some of the cryo. We can chop it off. We can excision. And if we do treat, it could come back, okay? Prognosis is excellent, but we also always need to rule out some of the melanomas. These are some of the videos, if you can see all of procedures to get those things out, right? So of a shave, of a punch, of a curettage, and an LN2. Here we go. This is what they look like. They all do not look the same, and so that's the reason why there's not of a textbook that is exactly looks like this. Okay, it can change, and so it's the reason why we will be doing some of the biopsies to figure them out. You can see it's all over, right? So it can happen. The entire back. Some more. All right. So these are what the keratosis looks like. Again, benign, but we're always going to biopsy just to rule it out, to protect our own assets, okay? Because of the fact that if it was of some cancer and you were just like, that looks fine, and then they get into the bad stuff, okay? Vascular insufficiency, xerosis. This is of the stucco of the keratosis. So it looks like it's just stuck on. It's there, and it's gonna, again, look like what the hell. More common in elderly, lighter skinned patients with peripheral edema, likely with edema. 1 to 10 millimeters, round dry, white or skin colored, papules, warty lesions. Again, like I said before, stuck on. That is of the measurements there of what the keratosis is. 1 to 10. Location, ankles, feet of the dorsal aspect. It can also be in the forearms or the hands, but most likely it's on the ankles. Like everything else that we're going to say over and over again, no treatment is required or desired due to poor healing. So we can, like with the other ones, we can do some of the curettage, we can do some of the cryo. Even if we do that, it's probably still, I'm going to come back. Completely benign. And that's what it looks like of the ankle there. Stuck on appearance. White papules. So now we're getting on to one that we've all seen on one of the best actors in the world. Who is it? Morgan Freeman, right? So he has this right here that oftentimes people ask, like, what is that? You know, again, it's all suspicion of what's on there. So it's of the smaller SKs. It happens on the darker. So it's of African Americans. It can be of some Indian, some Mexicans, Hispanics that could have this stuff. 2 to 3 millimeters dome-shaped papules. They are smaller ones, right? We just talked about the stucco, how it was 1 to 10. This one is 2 to 3. Brown to black, hyperkaryotic, pedunculated or varicious papules, female predominance. Location, it's on the face, right? So cheeks, the eyelids, you know, they're we could see those things. Teens to middle age, hereditary, and like I said, Africans and Hispanics. So the darker skin, you can see these things. No treatment necessary other than of a patient who says, fix this, I don't like how it looks, I don't want other people to question what is happening. If we do those things, then yes, we can do of the chiro, we can do some snips, curettes, remove, like I said again, it's of the shaving stuff, it's just you trying to remove those things out. If you're still just wondering, is this benign or is it that? Well, then you could do a biopsy on at least one of them if you are uncertain if it is or not. So that is what they look like. So it's more so on of the face. Talked about of the eyelids, of the cheeks, of the chin. You can see those things that are there. Skin tags. Skin colored to brown. They are soft, pedunculated, and then we can see there's some of the size 1 millimeter up to centimeter. Eyelids, neck, groin, buttocks, axilla, and waist. This is most common in obese patients. 25% all people after age 25. Scissor, electro, cryo, anesthetize, excise. So whether or not we decide to do these things, smaller lesions, we'll get those things without the anesthesia. But if it is larger, then we would have to excise that, and we would have to numb them up. If we cut them off, then it's not going to come back on its own. Could they get some other ones? Yes, but the one that you take off is not going to come back. Everything that we will cut off, excise, we'll do a biopsy every single time just to rule out and to protect ourselves and to let the patient know that you are smarter than they think, okay? So send it to Path and have it come back and let us know that we are right. So we can see it here. It's a tag. It can be a large one, right? So we'll excise that one because it's a big one. All right. Dermatofibromas. Oftentimes this is process of a trauma. So we're seeing there of a bug bite, of a viral infection. It can happen with some of the shaving. Key word right there, dimpling. So if you have this and you think that it could be one of these, you can take your index and of your thumb, squeeze onto it, and it's going to go in as a dimpling. So that is one of the things that is very cognitive. Dry mouth. It's key. Okay, so if you see some of that, then you will know exactly that it is one of these fibromas. 3 to 10, slightly raised, pink to brown, scaly, retract beneath skin surface with compression dimpling. Most common in of the lower legs, but you also have it on of the shoulders and upper back. Completely benign, like everything that's in this lecture. Removal of a punch or excision. Again, if we see one, we're going to take it out, send it off for testing to just make sure that this is not a cancerous process. That is what they look like before we are squeezing onto those things. So it's just up, there it is. And then once we do squeeze onto it, we can see the dimpling, and that's what you see right there. Scars and keloids, these are things that have been abrased. We've had some of the issues to where there was of an injury there, a surgery there, or some other things that just allows it to build itself up. Raised, red, hyperpigmented, firm, shiny. Of the scar, you would see that at of the wound site. Okay, so again, if you fell onto a fence or something and you got that of an injury scarred up, then you will see it. Of a keloid, that's a large of a scar. Okay, so it's of a wound site. Oftentimes, you will see these things as it builds up. I know that throughout the years, most commonly I would see this in females who had ear piercings and stuff, and then afterwards they would take that out, but it would build itself back up because of the holes that were put there. Scar, any place. Whereas of a keloid, it's most common on of the shoulders and then of the chest. Predisposed individuals, wounds, with of the scar, it may to soften sometime, but of the keloids, it's not going to do that. Okay, it could be painful, it could be itchy, or sensitive. So it's the scar and of the keloids. Like everything else, I'll just stop saying it. Okay, there doesn't have to be treatments of these things. Okay. But it occurs more of the cosmetic stuff. So you have of a patient who's like, please take this away because I don't even know what it looks like and I don't want anybody to not date me because I have this damn thing on me and it's gross. If you're going to do those things, surgery, cryo, silicone, 5FU, and lasers could help them with these things. We could be using some of the intra steroids, but that could cause, some atrophic effect on that there. So steroids are effective, but they hurt. Healing should avoid trauma to skin. Can recur if treatment stops. So if we're going to be doing some of that collagen, then it could reoccur if we stop it. So that is one of those there on the back of the ear. That is of a scar. Keloid. We talked about it as of the shoulders and of the chest. That is both of them, right? So that's a scar in of the middle, but it's also building up some of the keloid where that was at. That could probably be some surgery or excision because the keloids are where all of the needles were sewed up on, and then the scar smack in the middle as it got healed up. More all over. All right. Again, this is benign, but that one looks like hell, okay? Because it's got all of the stuff on it that we are going to excise, to biopsy, and prove to of the patients that it is not something cancerous. Solitary, discrete, smooth, dome-shaped, and it's got that of a papule or tumor in that location, okay? 1 up to 2 centimeters is usually what this is. And talked about the hyperkeratotic cord. Often indistinguishable. Okay, so what does that mean? That means if you look at it, it could look like it's squamous cell carcinoma. They look alike. It's hard to see if they are or are not. So it's one of those things that we also have to excise. We have to do the biopsy just to rule out SEC. That's what it looks like. It's like, here we go. That's no bueno. So let's go ahead and check it out. Again, back of the ear. Like I said earlier, the patient has it and they just want to see what it looks like, then they'll come to you. But they could be seeing you just because of a knee pain, you know, their high blood pressure, but you see it and you're like, how long has that been there? You know, da 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 da. And then check it out. Yeah. How long has that been there? It's on your nose. You see it every day when you look at your face. All right, so here's the horn. White to yellow, hard, conical lesion. Papule, plate, or nodule. Sun exposed, it's more men than of the women. And again, fair of the pale light and older, right? So years and years of all of the stuff on it to do those things. Benign, but SCC, it could be the carcinoma. Squamous cell of the carcinoma, so we need to check it out. I think that it's got a great name as a horn because it looks like these people have horns on. Excise, may shave, use of the cryo to figure this out. Off to the path. All right, hyperplasia. This is essentially those of the glands that are enlarged. Benign is small yellow papules, dome-shaped, umbilicated, right? So it can look like a belly button. Where do we see this at? Again, on the face. Most of these things are exposed to all of the locations that could get the sun exposure, okay? So that is why we're not seeing a lot of benign stuff on our groin, right? Because it's always covered up, which we hope, unless you are a contestant on Naked and Afraid. I like that show. No treatment is required. However, if we are going to do some of those things, we can chop it off, we can shave it off, we can fry it up with some lights. If this is the case and the patient wants it treated, then we're probably going to refer them to DERM so that they can get the retinoid there to treat it. Most of these things, like refer to DERM, that looks gross. refer to DERM, you know, itch and itch and itch. But that's not going to be all of the testing answers, right? Because we have to know what to do for these things if we don't have a dermatologist near us, because we're somewhere unsafe location, or yada yada. Must differentiate from the basal cell of the carcinoma. So we're going to do these things to rule those out. So we're going to scope it, and then we're going to expose and to do the pathological testing. Again, benign, benign, benign. That's the name of the lecture, so it's on all of the slides. And that's what they look like. So that's up on of the forehead. You're not easy to know where that's at, but that's what it looks like, because it's that enlarged of a duct that is occurring. More, we talked about how it looks like of a belly button. So you can see that one right there that looks like that. Of the nose. Again, on the face. On the face. Sweat duct of the tumors here. Again, small, firm, flesh, colored dermal papules under the eyes, so it could be on the lower lids. Again, this is where our sweating ducts are at. Less commonly on the forehead, chest, abdomen, and vulva. Presence with younger women, typically in the 20s to 30s. It's asymptomatic, right? So it's not hurtful, it's not itchy, it's just there looking at it, and it's again why the patient is going to come see you. If we were having some of the stuff, then sometimes you'll have a patient who is scratching at it, so it can cause some scars just because of the fact that they want to get rid of it. If we're going to be doing this of cosmetic, then we're going to freeze it, shock it, scrape it, and these things are done. It could be some scissors, a blade to get those things there. And that's what it is. So that's on the lower lids. That's the sweat duct. And so those things are right there. I'm flying through this because I'm the end of y'all's day, right? No?
We have the company community.
Ah.
You're less academic.
Okay. But the Air Force gets to leave, or?
No.
Oh, it's everybody. Okay. All right. So here's the fibromas. Grow on nerves throughout of the body. So it's nerve, neuro. Flesh to pink-ish white, soft, pedunculated, 2 to 20 centimeters. Buttonhole sign. Location, anywhere. It's not specific like the ones that we have already talked about, where it's on the eyes, the face, cheeks, ears. This one can be anywhere. We can see occasionally it can be segmented, it can be waxy. This can happen after we're not being children anymore, but we're adolescents. We're grown up and we can do anything that we want to. The arm pits, we can see these things where they're at. Management, nada. If it's there, it's there. It's not gonna come back if an individual wants you to take it away. If they're having this, then we would all hope that they have a neurologist who is into this as well. So if you think it is, you could refer them to DERM. DERM says, I don't want this. Refer them to neuro, back and forth. So it's a train. Benign, again, like everything else. But then it's, yeah. So there it goes. Nerve stuff. Large. Huge. All right, let's get into the cherry. Most common vascular malformation. Sometimes, well, not sometimes, usually it's individuals who are over the age of 30. 0.5 to 5 millimeters smooth, firm, deep red papules. Oftentimes this is seen on the trunk and the proximal extremities. You can have few or you can have many. There are the cherries. Treatment, don't have to do it, but if we want to do, then we will shave, excise, or blast it with ablation. More of the cherries. All right, so here is telly. So this is all of the small of the vascular that is just out, and you can see it through the skin. It's not up on top of the skin, but it's under the skin, okay? Appear as single strands or groups of the macules. Usually if you're having this, yes, it will be some of the sun exposure, but it could also be because of the fact that you're having some other diseases that this will show it out to us all. There we can see it over there. So that is what it looks like. It's just like some of the small of the vessels that are there. This is also specifically one of the things that's called of a spider. So you have that spider under your skin. Because of the fact that it is just right up and under of the skin. Spider legs, spider angiomas. Again, we will laser them to just to take them out. And that's what they look like. And as I said, we will refer them to DERM for electricity. Okay, so electro. Granuloma, pyogenic granuloma, vascular lesions of the skin and mucous membranes, common in children and young adults. So when we're younger, this could happen. We could have this also with some of the pregnancy, that we're seeing this on the gingiva. You can also see this with some of our acne who are on a retinoid. This is friable, so if we have some of the trauma that is having us with some of the bleeding that is hard to control, that it can then form into one of the granulomas. That is what they look like. Small, less than 1 centimeter, rapidly growing, yellow to bright red, dome-shaped and glistening. Head and neck, fingers, and the pregnancy gingiva. pregnancy. All right, treatment. Again, we can use some of the curettage of the base and of the border. We can electrify them to get them out of there, especially if we need to control of the bleeding that is producing or it's giving it more than it should. It will happen again if you leave some of that tissue there. So if you're going to cut it all. And that is what they look like. So we've got some of the young ones there on of the lip, and then we can see them on the other locations. Granuloma. All right, last one. Save the best for last. When I was in phase 2, I was on my the surgical rotation, and as I was in there, I was with the PA at that time, and I got lucky because one of his patients that he was seeing like every 2 weeks had lipomas all over his body. So like I sat there and we did it for like 2 hours and we cut out like 30 of those things because it was just off and off and off and off. So it's soft tissue. It's you know it's just what the patient wants to cut these things out of me. Okay, adipose tissue. So it's fat. Most common benign soft tissue of a tumor. Soft, pillowy, mobile. 1 up to 10 plus of the centimeters. I can tell you, like that guy, he had them like this big and all over. It was just like, wow, this is fun. Extremities, it can be on of your core, so of the back, of the chest, legs, those things. Any age, okay? Asymptomatic. It's not hurting them. It's not a painful thing. It's not tender. It's just there, and it's like I said, it's a pillow that is stuck in your body. What are we going to do with this? We are going to take it out, or just tell them to sleep well on all of their pillows. And once you take it out, it's not going to get back in it. Okay. You can excise it out, just like if it's a cyst, right? We have to remove all of connections there to get it out. That's what they look like. That big pillow up on the dome. There are multiple ones in there, so I can see 1, 2, 3. Could be more, but it's just not showing itself. All right. All of these things are cancer, right? No, they're benign, okay? So these are the things that you will see. But if you see it and it scares you or it worries you, what are you going to do? You're going to take it out and send it off the path just to prove that you are right. Okay? All right. Y'all could probably just get a hold of a briefer, right?
Yes,
And say, Mr. Supply is done, so get your ass in here.
Yes, sir. So, the company command team will be here at 13:50. This is the sign-in sheet for the brief. Everyone needs to, your names are on here. Just sign next to where it says signature. I'll start it in the front, pass it around, make sure you sign next to your name, and they'll be here at 13:50.
So I ended it.
No question. This actually, I gotta grab it. Viernes, todos los I don't know. That's a German. Right time. Domingo.
Care more than the girls do. Yeah, much care more.
It's very soon. I thought they were going to have if they've been stable for 3 years, and the genders is 4 You've had any days, surgery, automatic. and have it issues and glasses, which will be pretty much hard for anybody. While some people might fall into that category because they went through a phase when they were teenagers or something, it'll be hard for somebody to be like, oh, you guys know about it, but I haven't had to do it for 3 years. It's kind of like saying, I just do it the way I do it. Hey, look, we have exceptions. But it's not. So of course, if you're accepted to
Hello. Hi, everybody. So we having a good Thursday? It's almost Friday. All right. Hey, so just out of curiosity, were you guys any one of the ones that Sergeant Major stopped in the hallway with the headphones? Okay. Just do me a favor, just for the time being, just stay on the 3rd floor with your pacing and you're going around and studying and stuff like that. Air Force, Marines, I don't know what your policy is. Navy, I don't know what your policy is about headphones. But at least Army, just stay on the 3rd floor if you're gonna pace, okay? I'm all about you guys learning, and I know that that's a way that people learn, so, but don't go down to the 2nd and 1st floor and basement, please. Thank you. Side note, okay, so literally I went through this yesterday with the other 2 classes. She's gonna come in, she's going to pass it out if you want it. And then Captain McCoo, you sent it out, the digital copy.
Yes.
Everybody had the opportunity to review. That's literally going to be it. She is not going to be able to answer any questions. You're not gonna be able to ask any questions. If there are any questions that you have towards the X-Ord, just go ahead and type it up, put it in like Canvas or an email, and I'll send the RFI up. So I would say, are there any questions? But yeah. So, all right, everybody cool? All right. Oh, come in, Mendoza.
Is that sign-in sheet still going around?
Yes.
Okay. Just making sure.
I was actually going to try to study
Did you see your amended letters? Okay. I really hope they all get worked out. Did you put the CRM and stuff in? Do it as soon as possible because I don't want them to get